Okay, so good morning, good evening from wherever you are. Thanks for joining today's EPI-WIN webinar. My name is Catherine Sheridan. I work at the World Health Organization in Geneva, and I'm filling in for our regular Sarah Hess. Welcome. It's a pleasure to have everybody here today. And yeah, definitely post where you are in the chat so we can see where everyone's participating from. This is the first webinar in a series on mental health. The title and theme of the webinar today is Mental Health and Psychosocial Support During the COVID-19 Pandemic. We have some great speakers with us today to talk about some of the important work that's been happening in different contexts over the last year. Introduce them. So we have Fahmy Hanna. He's a technical officer working at the Department of Mental Health and Substance Use, also at the WHO in Geneva. We have Deborah Magdalena, who's a coordinator for the Mental Health and Psychosocial Support Technical Working Group, working for the International Organization for Migration in Nigeria. And then we have Maya Taka, who is also a coordinator for the Mental Health and Psychosocial Support Technical Working Group. This is going to be a tongue twister today, working at the United Nations Population Fund in Myanmar. So as normal, if you do have questions for our speakers as we go along, please add them to the Q&A function at the bottom of the screen. And we'll have after the presentations, we'll have a Q&A session. And just as a reminder, this webinar is being streamed to YouTube. I'll post a link in the chat shortly as we get started, and we'll also share the slides and the recording to everyone that registered to the event today. Okay, so I think that was all the housekeeping. So I'm going to hand it straight over to Fahmy to get started.
Catherine, thank you so much, and thanks to you and all EPI-WIN colleagues who work on the risk communication and community engagement pillar of the incident management for COVID-19 response for prioritizing this topic and having this mental health webinar series, such an important topic. I am aware that the composite term mental health and psychosocial support is a difficult composite term, and actually it was coined back in 2007 with the release of the Interagency Standing Committee guidelines on MHPSS, or mental health and psychosocial support, and it represents two words: mental health, which deal with prevention and treatment of mental disorder, and psychosocial support, which deal with protection and promotion of psychosocial well-being, and really combine actors from all UN agencies, international NGOs who work in this area of work. So that's why you will find me today working with the World Health Organization, my colleagues from UNFPA, other colleagues from IOM. If we have colleagues from IOM, from UNHCR, from UNICEF, from International Medical Corps, from World Vision, all of us will use the same terminology because it really using this composite term bring consensus to this field. Let me start with my presentation. I hope you can see my slides. Thank you. I'll share with you an overview in the coming 12 minutes about mental health and psychosocial support during COVID-19 pandemic. I'll start from a very important event that happened last month at the World Health Assembly, the governing body of the World Health Organization, when the 194 member states, 194 ministries of health has agreed on a decision to integrate mental health and psychosocial support as an integral component of public health emergencies, preparedness and response. It was really a historic moment because the first time that mental health discussed as a separate agenda item at the World Health Assembly, and the Assembly has endorsed the extension of the Mental Health Action Plan until 2030 with new implementation options and new indicators. So one of the indicators now will have all countries of the world reporting every 2 years on mental health and psychosocial preparedness. Our target is that at least 50% of countries have a system for mental health and psychosocial support preparedness with investment of financial, human resources, having impact evaluation, as well as plans for action in this area of work. This would happen last month, but let's step back and look a bit at the service. When we look at the service for mental health globally, there are no good news. Very limited good news. In fact, when we had the Pulse survey for disruption of mental, neurological, and substance use services, which was a component of essential health services in both surveys, we found consistent finding in 2020 and 2021. Among all essential healthcare areas in health sector, among all areas, mental, neurological, and substance use disorders were the most disrupted, the most frequently disrupted, and the most severely area which reported as disrupted. Just a little higher above neglected tropical disease, but the most disrupted area in health systems. I think this can simply be attributed to decades of neglect and underinvestment in this area, which led to the current situation on having this as the most disrupted area. Majority of governments of the world spend less than 1% of their health budget on mental health. When there is an impact on health system, we see that most severe in this area of work. But let's zoom in with the data from Pulse survey. We said mental, neurological, and substance use service were the most disrupted, but within these services, there are a wide range of services. So let's see together what was most disrupted within mental, neurological, and substance use. In fact, the service we need the most were the ones most disrupted. Service for the most vulnerable, school mental health services, services for older adult, child and adolescent mental health services, emergency psychiatric services, which are life-saving, overdose prevention and management, critical harm services. These are the type of services for the most vulnerable groups, which shown to be the most disrupted services. But there are some good news. In this survey, which was published 3 months ago, the Pulse survey, and also in a similar survey which was conducted last year between June and August, in both surveys, we found a consistent finding. Around 90% of countries have reported that they integrated mental health and psychosocial support as an integral component of their COVID-19 response plan. 82% of countries reported that they are doing at least one activity for mental health and psychosocial support. Most commonly, this is around orientation of responders on basic psychosocial skills, but also services such as providing mental health and psychosocial support to patients with COVID-19, as well as other services which are listed by or activities listed by countries here. But back to the bad news again. Only 49% of those countries who have integrated mental health into their COVID-19 response plan reported allocation of financial or human resources to implement such a plan. Only 20% of those countries have reported availability of full funds to implement the activities they have included. So again, limited investment in this area of work before COVID and limited investment despite recognition during COVID-19 response. Only 20% allocated full funding. And the same result, by the way, was consistent in 2020. Almost 17% in 2020 have reported full availability of funding. So still a problem of underinvestment. This is a very interesting slide. It tells us how MHPSS is coordinated both in humanitarian emergencies and in public health emergencies. In humanitarian emergencies, the agreed model within the Interagency Standing Committee at country level for MHPSS coordination is that this is an area of work which is cross-sectoral. This is not an area of work under protection cluster or under education cluster or under health cluster. This is an area country level MHPSS technical working groups should be cross-sectoral technical working groups. In good humanitarian practice, you will find actors for mental health, integrating mental health and general health care, in education sector doing school mental health promotion, in GBV doing MHPSS aspects for GBV survivors. All those actors meet at country level in MHPSS technical working groups that we will hear from my colleagues Maya and Deborah. Both of them are leading these country level coordination groups at country level, how this group function day to day and respond to challenges in humanitarian emergencies. But MHPSS cross-cutting across sectors, also MHPSS within sectors, so within public health emergencies, it is also cross-cutting across pillars. We work very closely with colleagues in risk communication and community engagement, for example, to promote stress coping messages among risk communication, but also we would work with colleagues working on partner coordination for MHPSS coordination in countries, with case management to make sure that in case management for COVID-19 and other public health emergencies such as Ebola, MHPSS is integrated. We'll work with colleagues who deal with continuation of essential health services, pillar 9, on continuation of mental, neurological, and substance use, and assessments such as the pulse survey you saw. So MHPSS is cross-cutting across sectors and within sectors such as in public health emergencies, across wide range of public health emergency pillars. At country level, multisectoral MHPSS technical working groups is in fact the indicator for MHPSS in the strategic preparedness and response plan for 2021, and was also the same for 2020. We saw that between March 2020 and January 2021, the number of countries with active multisectoral MHPSS technical working group has increased more than twofold, actually from 22 to 53 countries. Remarkable recognition from countries for the importance of MHPSS coordination. And again, we'll hear concrete examples from my good colleagues Maya and Deborah today. Let me take you through some of the highlights of MHPSS during the COVID-19 response, some of the key achievements and highlights of activities. First, coordination for MHPSS at global level started very early in the response. As early as late January 2020, we start to have our global and country-focused MHPSS coordination calls with different actors. And we continue, the same habit continues with these calls, either at global level or with country level MHPSS technical working group chairs. For the first time, MHPSS was integrated into the global humanitarian overview by OCHA. MHPSS was considered as a cross-cutting topic formally, similar, for example, to gender by the ISC in also joint interagency call for action by heads of WHO, heads of UNFPA, heads of IOM, head of UNHCR, head of OCHA, and head of UNICEF. That was released last year, with MHPSS clearly recognized as relevant for all sectors. MHPSS start to be integral component of high-level meetings from UN General Assembly to Humanitarian Networking and Partnership Week, including into most recently the World Health Assembly. We haven't seen that before COVID-19. Rarely mental health would be included in such high-level event. And a rapid deployment mechanism for MHPSS coordination was launched, with so far in 15 countries deployments in 2020, and also 12 additional countries during 2021, 27 country level deployments of MHPSS coordinator through an interagency deployment mechanism run by Dutch Surge Support, one of the standby partners, with support from WHO and IFRC, and hosting by IOM, UNHCR, UNICEF, and WHO. Wide range of practical tools was developed through the interagency standing committee, through WHO working closely with partners including UNFPA, IOM, UNHCR, UNICEF, and others. For example, I'll focus on 2 or 3 of the ones you see here. Of course, the children's storybook, which became very, very popular resource, now available in 143 different languages and 50 plus multimedia animations, multimedia products. This product provides children from 6 to 11 with key messages through a story about how to cope with day-to-day stressors related to COVID-19. A new version currently is being updated from this resource that will be released with the next school years, and the resource is developed based on a survey conducted across numerous countries. Last year, we did it in 100 countries with input from around 2,000 children, their caregivers, and parents. The other resource here is basic psychosocial skills. We learned early in the response, we need to build the capacity of frontline responders to integrate basic psychosocial skills in their day-to-day work. With frontline responders, I mean all essential workers, not only health, but social sector, law enforcement, food distribution, everyone, how they day-to-day improve the psychosocial well-being of others. The third resource here, Living with the Times, the one just next to the 34 languages, because it's just released. It is one of the first interagency tools which are available for mental health and psychosocial support of older adults, people who are 65 years old and their caregivers. I continue with the highlights of MHPSS interagency work. MHPSS became part of the Global Humanitarian Response Plan by UCHA, with activities included for the first time, actually, in Humanitarian Response Plan by UNHCR, UNICEF, UNFPA, IOM, UNRWA, and WHO. The Secretary General and WHO and partners were the pen holders for this important policy brief by the Secretary General on COVID-19 and mental health. And following this important policy brief, there was a letter being submitted to the UN General Assembly by 90 member states requesting scaling up of mental health as part of COVID-19. MHPSS monitoring indicators became part of Strategic Preparedness and Response Plan, Global Humanitarian Response Plan, and UN Comprehensive Framework for Response to COVID-19. And finally, we saw at the WHO Executive Board and at the World Health Assembly the recognition of MHPSS as an integral component of public health emergencies, again, for the first time. But one of the most important achievements is really country recognition. The fact that 90% of countries are including mental health as a key component in their COVID-19 response plan, I think is quite an achievement in recognition and advocacy at country level by many partners. This is one example here in a map. This is Syria. The current dots you see here in different colors actually are primary healthcare centers integrating mental health as part of the essential healthcare package. 1 in 4 of every Syrian functioning primary healthcare center, in fact, have mental health integrated. And that compared to only 2 psychiatric hospitals and only 2 cities in back before 2011 during the conflict. Because of or despite of the conflict, many partners was able to scale up services in 13 cities in Syria. To see the map you see here. There was during the pandemic also scale up of mental health services in South Sudan, in Juba. Service start to be provided in 7 South Sudanese states outside Juba. WHO in Libya, for example, with partners are implementing a scale-up project for funded by DFID to integrate mental health at primary health care. Community mobile teams scaling up the response in east of Ukraine in conflict-affected area, introducing community-based services for the first time. All these are just examples, but there are huge number of other initiatives, including the one you will hear from Myanmar and Nigeria today. The integration across pillars also is ongoing on normative guidance. So mental health is an integral component of the WHO guidance on essential healthcare services. There is a mental and neurological chapter in the clinical management of COVID-19. And for example, the health cluster have an MHPSS clinic that was conducted several times during 2021 to provide programmatic guidance for health cluster partners on MHPSS aspects. Some of the forthcoming tools is this one, the monitoring and evaluation framework for mental health and psychosocial support, which will be released by the ISC. This document is key, and we have been working on this for quite some time now. It will enable MHPSS partners for the first time to measure collective impact of this area of work at country level. We are working with the WHE Open WHO training platform to develop an MHPSS online training targeting humanitarian health responders. And finally, a joint project now done by UNICEF, UNHCR, recently joined by UNFPA and also WHO, is to scale up, is to develop and pilot test a minimum service package for mental health and psychosocial support in humanitarian settings funded by the government of Netherlands. I'll stop here and back to you, Catherine.
Thank you so much, Fahmy, for the huge amount of resources that you took us through. And also it's really interesting to hear that the MHPSS is being taken up in so many different countries and the kind of coordination efforts across all these different organizations and clusters. I'd like to hand over now to Deborah, who is also a part of the MHPSS working group and working in Nigeria for the International Organization for Migration. Thanks, Deborah.
Very much, Catherine. So yeah, before I start, I think I really exactly the same as you said. It's very interesting to hear from what Dr. Fahmy already shared, and knowing all these global efforts and also the advocacy. And I think we're really proud to be in this area now. And then yeah, so I think we're looking really forward to to more efforts that we can do together, especially also from learning experiences from the country level that can really supporting, especially partner in this area. So from my end, I will share some of the information and maybe some lesson learned or best practices that came from the Northeast Nigeria. This is as in my capacity as the MHPSS Working Group Coordinator for the Northeast Nigeria. Just before we start, so I can share that the MHPSS working group in the Northeast Nigeria is comprises currently, based on our latest mapping, is like the number is around 49 partners, and it comprises from the civil society organization, national NGOs, international NGOs, Red Cross and Red Crescent movement, and then we have UN agency and also other government agency and stakeholders. So I think we can go to the next slide. I will try to give maybe some of the context, especially within this context of the Northeast. So basically the crisis is within the area of 3 major states, which is Borno, Adamawa, and Yobe. And based on the humanitarian response plan on the 2021, so we consider that the crisis in these 3 particular states is expected to persist in 2021. So, and a total of 8.7 million people in need of humanitarian assistance in 2021. And then some of around 1.92 million people are actually displaced internally, and around 257,000 living as refugees in neighboring country, which is bordered with Nigeria, Cameroon, Chad, and Niger. So the majority is around 54% of the internally displaced people is actually taking shelter around the host community. And Borno state is hosting around 81% of the IDP. So we can imagine this is the crisis setting that happened even before the COVID-19 pandemic. Because of the insurgency of the Boko Haram. So the issues here, we have the area of congested camp. We have also an increase of fire outbreak because of the weather, which is very hot at times. We also have a flooding issue during the rainy season. We have issue on the water, sanitation and hygiene, also food security, malnutrition, and especially in the limited access to the health facility, and also multiple disease outbreak, and also increase of social violence and abuse. So COVID-19 is basically adding the difficulties and also the distress among the displaced population, and then it's creating like another psychological condition, of course. So the next one, I can share maybe the one that the next slide, Catherine. The next slide is about I'll have a continuity on what is really situation there. So basically, IOM displays tracking metric, or it's called DTM, in collaboration with WHO and the State Ministry of Health, is conducting monitoring the movement of individuals to and from Nigeria's conflict-affected state that I already mentioned. So the assessment are conducted at point of entries located along the border with Cameroon. And the movement is, there's various reasons actually why people moving in and out from within the border. So it's one of the main reason is because of the seasonal. There's also family visit, economic migration, also forced due to the insurgency. And then mainly 42.9% is the mode of transportation is actually by foot. And this is the snapshot based on May 2021. So we understand in regards of the COVID-19, the movement between people and between borders is actually can be increasing the effect and also the increasing of the spread of the COVID-19 itself. And that's also the reason why it's really important to see on the numbers and why there's an assessment being conducted, and especially in the point of entry. In 2020, when the assessment was conducted, there's also one of the reasons that being captured, which is due to fear of COVID-19 and also health conditions. But nowadays it's a bit reducing, and the main reason is actually based on what I already explained. So as I already also shared a little bit, that it has, in particular, all this has a major impacts on the overall living standard, also in impacting on the physical and psychological well-being. Also the capacity of these individuals or the displaced individuals for the resilience and having a positive coping mechanisms within the IDPs, in the returnees and host community. As we say also in the movement, there are some groups of vulnerability, which is people breastfeeding, pregnant, single parents, and working the difficulty. Next one. So what we can do now, we already, I think we all agree that the COVID-19 pandemic is creating some kind of psychological condition, especially on the people who's already experiences of the crisis in this context of the humanitarian crisis. So they have the issue of anxiety, fear, confusion, and also frustrations. And also there's increase of cumulative family tension. There's also intimate partner violence and GBV or gender-based violence, not having access to food with issue of economic hardship or lack of livelihood, this is actually one of the main key that's really impacted in this area. And of course, there's also limited access to the services that include MHPSS or mental health and psychosocial support during especially the peak of the pandemic. And of course, the other one is about worriness to visit the healthcare facility due to the high level of stigmatization that is actually really high within the Africa context. So we are really seeing how important it is, our program within the MHPSS partner, to have a multisectoral and coordinated responses, and also the localization strategy or building on local capacity. The next one. I will share what is the collaboration efforts that we've been provided, and also how we can also scaling up our mental health and psychosocial support responses. So again, during this pandemic, we see how difficult it was for partners, especially for the international staff, to go into the location or IDP camps. And we see this as a momentum that how essential it is to have a localization strategy or building the capacity of local organization to carry out the activities. So there are some other activities that I can maybe share. First is about the State Ministry of Health and WHO and IOM in collaboration with the government agency and local partners. They provided psychological first aid and also community awareness and health and hygiene sensitization at the point of entries, the one that I already mentioned before. And then there's also an assessment that conducted by IOM about the perceived community perception about the COVID-19. This is to gain insight, what do they really perceive about the COVID-19, because at that level, it was a high level of stigmatization, there's disbelief that it might be like not happening. So all these things and all the recommendations were shared within the coordination meeting in the health sector or protection sector, GBP and child protection. So there's also a lot of various capacity building activity that are organized by partners and also to the actors, health worker, government official, and also in different related topics on MHPSS. The one that already shared by Dr. Fahmy is on the basic psychosocial skill. Also link with the psychological first aid, but in the context of the outbreak and other relevant topic, especially for the health workers who's at that time working at the isolation center. So there is another one that collaboration that we did within the child protection subsector, which is a development of catalog of activities and games that can be done by home or within the community or in child-friendly spaces. Because if you remember, it was really difficult for us to have like a really large group, especially with children at the child-friendly spaces. So we try to develop some of the catalog for them or parents or the caregiver, or maybe some of the community leaders who can develop or maybe can implement these activities. So it's possible for them to do it within their area. And there's also a guidance on how the level of person-to-person contact to be taken as consideration before engaging children in this activity. And it's mainly based on the local type of games and activities. Yeah, next one. So another, maybe two other points of collaboration efforts that we conducted, mainly MHPSS partner carry out their MHPSS COVID-19 activity based on the house-to-house or phone consultations, and also the support room in the safe space with a smaller number of individuals. We also still do the referral to specialized services for the area that have an ease lockdown regulation at that period. And we also have a toll-free numbers that was managed by Medicine du Monde and also supported by MHPSS partners at this period. So another maybe point that I already briefly mentioning about the deep concern over loss of livelihood and also increase of distress and anxiety that mainly resulting from the social economic impact of the COVID-19. So this is the reason why at that time period of the several MHPSS partners, they integrated the MHPSS and livelihood support in the situation through the face mask production training. So it can really help to have an income generation activity, especially those who's been really affected by the economic side. So I think within the humanitarian crisis center, access to food also become one of the main challenges. So having the income generation activity can be really helpful for them, because sometimes the fear is not only about the COVID-19 itself, but also the other relevant social issues that coming within the area. So the last one from our end, from the Northeast, that I can share is that's actually the activities that partner conducted. And then what Dr. Fahmy already shared before about the tools that developed by the Interagency Standing Committee, MHPSS reference groups, it's really helps. I can share that there's various of development or tools that been created because we have a really close engagement within the health sector with the State Ministry of Health and with other area during those periods. So within the Borno State Ministry of Health COVID-19 Preparedness and Response Plan, within that published in March 2020, there's a component of MHPSS. And also within the COVID-19 Preparedness and Response Priority for the ongoing humanitarian situation in the Northeast Nigeria, there's also a component of MHPSS, as well at the multisectoral response strategy of COVID-19 in the Northeast Nigeria. And then we understand that partners is also adjusting their project proposal and MHPSS activities to link with the COVID-19 responses. And I think this will be really, really useful for us to ensuring the sustainability of all programs. And the last one is about the National Interim Guidelines for Clinical Management of COVID-19, this is under version 3 in June 2020 that already including the mental health and psychosocial support. Because before on first version number 1 and number 2, the MHPSS is not captured. So I think we have the advocacy, and of course with the tools that been supported by IIC reference group on MHPSS is really helpful for us to lead us and to guide, and also to put more advocacy at the national level and also at the area of the Northeast. I can also share maybe the last one about the collaboration efforts that we conducted through the Translator Without Borders. Dr. Fahmy mentioned about 143 translation on the My Hero Is You. And from us, we are translated into 9 local languages. It's also they have an audio file for this, and also on the basic psychosocial skill guide for COVID-19 responders. We also translated this into 3 main local languages. We understand that all these tools can be really useful if it's been translated into the local languages. So more community and more maybe even national staff can use it and also can be benefiting from this. I know that Maya will touch base more on these 2 areas. So I'll stop on here and then I will share with, I'll hand it over to Catherine and to Maya. Thank you so much.
Thank you, Deborah, and thank you for talking about some of the really interesting and important work, but also the challenges of being in the context. Okay, I would like to hand straight over to Maya for her presentation. And just a reminder, if you have any questions you'd like to ask our speakers, to pop them in the Q&A chat down the bottom. And let me just pull up the slides for you.
Thank you, Catherine. Yes, so I'm very happy to be here today representing the technical working group in Myanmar. I would first like to say that our technical working group is open to UN agencies, INGOs, local NGOs, academic institutions, and interested groups or individuals that are active in MHPSS in Myanmar. And we have very active participation from our members and have numerous initiatives that are supported by our working group members, particularly based on their technical expertise as well as their interest. So yeah, with the onset of COVID-19, there were two particular identified needs that was identified by the technical working group. And this was the capacity building on psychosocial skills for first responders, as well as adapting our activities and approach in order to reach persons of concern within the context. So I will speak briefly about how we address these two identified needs as part of the Myanmar MHPSS technical working group. Thank you. Next slide, please. So first I'll start off with the basic psycho skills adaptation. So really with the onset of COVID-19, there was a great need to prepare first responders and essential workers with basic psychosocial skills to support persons experiencing distress related to the crisis, as well as to strengthen first responders' awareness of self-care and their own well-being. And this is particularly considering the burnout and stigma that first responders often face. So the Interagency Standing Committee developed the resource, Basic Psychosocial Skills, a guide for COVID-19 responders. The MHPSS working group translated this resource into 5 local Myanmar languages, and training was provided to first responders who were providing a range of protection and health services throughout Myanmar. Additionally, in this training, we combined an overview of the Interagency Standing Committee referral support guidelines to ensure that first responders are able to safely link persons experiencing distress to MHPSS services, as well as to other sector services. This training also included a briefing on local referral mapping tools that have been developed by the MHPSS Technical Working Group, and which are available as an open resource on our website. We are currently in the process of adapting the 5 language versions of this resource into online training, as well as an offline training because of the challenges of internet access in remote locations. The MHPSS Technical Working Group is also closely coordinating with the Child Protection and Gender-Based Violence Technical Working Groups to incorporate key training topics needed for first responders, referring and supporting gender-based violence survivors and in child protection cases. So a bit of a BPS plus in this case. And the technical working group really recognizes that capacity building must strengthen the ability of first responders who are often supporting communities that speak different dialects from the main language spoken in the country. So in order to truly build capacity of first responders who are also from these communities, the resources that have been developed at a global level must be translated and adapted to the local context with the support and input of local partners. Next slide, please. So moving on to adapting our activities and approach in order to reach persons of concern. So in Myanmar, with the spread of COVID-19, many MHPSS providers were not able to implement our activities as we normally would. We had to adapt our approach and ensure that MHPSS still reached people in times of lockdown, quarantine, and during movement restrictions imposed by the government. MHPSS activities were not allowed in many parts of the country because it was not considered an essential service during the outbreak. And this was really in order to reduce the risk of spreading COVID-19, particularly to the most vulnerable populations in the country, for example, in internally displaced persons camps. One of the initiatives to adapt our response was to gather information on available MHPSS services that could actually be provided remotely. So we mapped these resources with the collective input of our working group members, and we were able to share this information on our website as open access information for all. Next slide, please. As a technical working group, we also developed Myanmar-specific MHPSS resources that included information and supportive key messages in response to COVID-19, and published these picture-based resources in 6 local languages, as well as bilingual versions for border areas of the country. The MHPSS Technical Working Group COVID-19 MHPSS supportive material was mainstreamed into the distribution of hygiene kits, food distributions, and at health and quarantine centers. And through this coordination with numerous other technical working groups and local partners, we distributed over 300,000 MHPSS supportive material related to COVID-19. The resources include a booklet on stress and coping with COVID-19 for adults. You can see that on your left, which really normalizes stress reactions and gives practical advice for self-care. We also developed a booklet for parents on supporting their children during times of crisis, which provided information on how they can identify signs of distress and how to support their children. But the material mostly focuses on the self-care advice for parents, which actually really reduces the distress of children indirectly, directly. Okay, slide 5. Next slide, please. And finally, we developed a coloring book for children that aims to support them through the promotion of key messages on hygiene, health, and coping with COVID-19. This coloring book also provides a source of recreational drawing activities that can support children in times of physical distancing and during times of quarantine. So the coloring book includes 76 pages. We're just going to run through a few now just to show you, 36 of which are psychosocial activities based and key messages, and 30 are context-specific recreational images from Myanmar, including many ethnic groups being represented in the images. So I thought it would be interesting for you to see some of the images here. This is still some of the psychosocial activities, focusing on breathing activities, trying to be inclusive, as you can see in the imagery. So a lot of teachers were using this. We actually worked with a lot of education and emergencies partners and distributed about 160,000 of these coloring books just with education and emergencies partners. And we were very lucky to have, a source funding from IOM, who then coordinated the distribution of these materials at no cost to some of our CSO partners. And with every coloring book, a 12-pack of crayons came with the coloring book with 3 different tones of skin color. So yes, thank you so much for the presentation, or the, your attention. Thank you.
Thanks so much, Maya. Yes, I've made it to the end. Great. Okay, thank you all for your presentations. They were fantastic. And I see we have some questions in the Q&A already. So just give me a moment. And for anybody else that has questions for any of our speakers, please feel free to jump in. Okay, let's start with, I'd like to ask Maya and Deborah, you both spoke about this localization strategy. Could you expand a little bit more on an example of how a particular tool and how you localized it, or what was some techniques in the consultation process, perhaps? So first, Deborah, would you like to share?
Sure, Catherine, sorry, I need to move my screen a little bit. Yeah, I think that's really be like a really good key questions, because as I briefly mentioning about this context when the COVID-19 happens, and of course in major countries, almost all, we have the lockdown situations, which is at that time, there is no access for partners, even of course the international staff or the national staff, to work directly inside the communities or the IDP camps. So it was really difficult, and it was really hit us because it just kind of like stopped our response and we cannot do anything at that period. So we understand that in that critical situations, the only individuals or people who can work is actually the community itself, those living in the area who need to be really equipped with some basic psychosocial. So we are working together with our camp coordination and camp management to train, but of course it was afterwards. It was a really good lesson learned from us. So we trained the community of volunteers on the basic psychosocial skill, the COVID-19 responders. So we train them on, the model is really great. I think all the participants who can maybe already familiar with the module can see how it might be like more easy to adapt and also easy to digest all the modules, and it's really practical. So we are using, that's one of the experiences. So we train more on the community volunteers so they can work inside the IDP camps. We are also engaging with the like women communities, with the youth communities, with the community leaders to have all these skills. I think that's actually one of the key areas and also key strategy that we are trying to do, in addition to, of course, adapting the tools into local languages. I think that's from my end. Thank you.
Thank you, Deborah. Maya, would you like to add anything?
Yeah, so I would just say, for all the materials that we developed them with the feedback of mostly our CSO partners that are working in the field. I think that's the most important. But really with the technical working group in Myanmar, we always provide feedback and share resources. But I think it's really important to always receive feedback from the first responders, from the field staff on the material, even on the translations, the images, everything. So it is a process and it does take a while, but to do it right, yes, you have to put that time in. Thank you.
Absolutely, it's engaging the communities that are using it, and if it works. Yeah, thank you both for your answers. Okay, I see a question here from Genevieve, and I'm going to direct it at Fahmy, but if someone else has another answer, feel free to jump in as well. Okay, so I'll read it out. Thinking about the role media content and the producers of media play and can play in the COVID-19 response, such as providing content that builds skills to help people cope with all aspects of the pandemic and response. Is there something specific you would ask the media to address or communicate over the next 3 to 6 months to support mental health and psychosocial support for the general public? Or any particular issues or approaches that you think are needed?
I think it's a great question, Catherine. And one of the resources we developed early in the response together, in fact, in partnership with the EPI-WIN colleagues, was guidance on risk communication and community engagement in the early response. And in this guidance, we focused on messages that can be shared. So it was basically a repository of messages that can be shared through social media and media channels. It's about reducing stigma and encouraging positive coping methods and presenting good models also of work among health workers. One of the things that this pandemic has taught us also, the potentials that you get when you work closely with media professionals as integral component of your team when you develop materials. All the resources we shared with you today, and you see it was developed here by team in Geneva, but in close partnership with countries and used in many places, used in Nigeria, in the Northeast, used in Myanmar. In these resources, the media and also the art experts were not an add-on. We didn't share with them the text after we developed. They were an integral component of the team during the development process from outset. And we developed multidisciplinary teams with media experts and with comic art experts and with storytelling experts who were equal to the technical experts and providing their technical expertise in art and in media. So I think a key role with the media is to is to have real partnership, to work with them from outset. And I'll share here in the chat function some of the resources we developed.
Thanks so much, Fahmy. Okay, I have a question for Maya from Peter. What sort of approaches and techniques are being promoted to professionals in the field of psychiatry, psychology, or social work to help them address the secondary pandemics of mental health and psychosocial care, or the impact, on children and young people, especially in resource constrained settings? Oh, I think you're on mute.
Thank you. That's for in Myanmar in particular, correct?
Yeah.
Yes. Okay. So there are very, very limited resources in Myanmar, and at the moment, access is a major issue. It was before, but even more so now. There has been a lot of effort from certain organizations, certain higher level mental health service providers to really develop a stronger sense of providing remote services, but at a higher level, which is not psychiatrists, psychologists. It's still lower level, maybe CETA services, lower cognitive behavioral therapy services, but providing them remotely on the phone. Honestly, even the provision of psychological first aid over the phone. I believe there's about 40 psychiatrists in Myanmar for the whole country. So it's a hard question to answer in that case. But there has been this shift towards seeing the potential in remote services, particularly in contexts such as Myanmar. And, there has been a lot of global guidance coming out about that. And I think that's been incredibly beneficial. And that seems to be the way that it would be moving in Myanmar, particularly now for the lack of access to the field, to persons in need. So I think you're going to see a lot more development in that way, and hopefully that can expand even more the capacity and the reach that we would have. So I hope that answers slightly. Thank you.
Thanks. No, that's great. Okay, I'm just looking through some more questions. We've got plenty. So one for Deborah, perhaps you can also add after Maya, but this is from Peter. Is consideration being given to the possibility of engaging and equipping local religious leaders as first responders, particularly in the context of the pandemic?
Yes, wow, that's actually a really also good point. Again, on the context of Africa, it was a bit challenging in the beginning because of the level of stigmatizations, and people don't really believe on the COVID-19. So I think because they also experiences like multiple outbreak before, and then this is like a type of, how do I say this? They will not believe before they see with their own eyes, and the numbers might be different from other part of the world. Within this, especially in the Nigeria at that period, the main numbers of COVID-19 is actually within the dense area, which is in Lagos, and Abuja is the capital. So the religious leader, so people try, if they really feel sick, they try to engage with the religious leader, and what they provided is like a water being, with some praise. They just believe that this is a very very useful water, and then they just come to the priest, or they come to the mosque, and then to seek for the support. So it was difficult, I agree, and of course we work closely with a lot of partners, and also with the government level as well, to engage with these community leaders and also with the religious leaders. We even using the religious leaders who've been like a survivor of COVID-19 to spread the messages. I know they given a title as like a hero of the survivor of the COVID-19. I know it's somehow it's a bit like I'm not saying that this is really good kind of like practices, but we have to go that way to give an example and also a role models that they can really trust, because part of within this community, religious leader, community leader is the one that they seen as someone that can giving them an advice. So that's, yeah, I think that's really useful. And also, of course, we see the importance of it to engage with them. Thank you.
Thanks so much, Deborah. Okay, so I've got a question, speaking of heroes, to Fahmy. So you spoke about the successfulness of some of these global tools. In fact, all the speakers did, in particular, the children's storybook, My Hero Is You. So could you talk to us a little bit more about how this was developed, how the character was chosen, and the consultation, I guess, to make it the success it has been?
Thank you so much, Catherine. I shared in the chat function a resource that I mentioned in my response to previous question. So just want to alert our participants to this. It's the interim briefing note. But responding to your question about My Hero Is You and other resources as well, such as the basic psychosocial skills and others which were really successful. I think the ingredients for success of these resources is that they were developed user-oriented. It was really not depending on group of experts who decide what will be the content, or who would put assumptions, what are the issues that are facing families and children. It was based on a survey that we disseminated widely and tried to fill to get a sense of what are the stressors and what are the coping mechanisms. And during the development process, again, it was not only a group of experts who were developing it. Actually, whenever we develop a part, we were doing user testing in wide range of places. I mean, both Deborah and Maya actually are engaged now in the user testing of the new version of the storybook, and you can find more information about it here, including the survey. And similarly, we're doing the pilot testing in 20 other countries while we're developing, and still we haven't developed the drawings for the character yet. For every scene, for every instance, through storytelling, we get feedback, and we take every feedback we get seriously. One of the feedback we got from Nigeria was a concern about one of the animals presented, that it might not fit with the local culture. So we had to get advice from our colleagues who work in the field of anthropology. What is the meaning behind how can we modify, how can we select another animal and get back to the community and get their advice. Developing these products globally is not easy. And one of the interesting things we find is the main character, Aryu, who is an imaginary character, is not an animal, is not a specific character, but the way it's presented was looked like a dragon in some cultures. So we find that in those specific cultures, people were adapting the Aryu character into another character when they do the adaptation. So for example, when it was done in Native American, among Native American populations in USA and in Canada, Aryu character was adapted to an eagle. When it was done, when adaptation was done in the Philippines, it was adapted, I think, into a ship. When it was done, I think in another setting, it was adapted into a horse with a unicorn. So really, every culture would take it and adapt it to its local context. If you are interested in reading more about the dissemination of this resource, please check the link I just put here, including the dissemination report, including some of the adaptation, how this resource was uptake and used in countries. So to summarize, I think it was really listening to the field while developing, and listening to the field before developing, and working together with the field for cultural adaptations as we go on providing support. I think also using a common logo like the ISC, which is an umbrella, would make every organization disseminate the product as its own. And it's right, it's their own product, because under one neutral logo, every agency would perceive the resource as their own, which I think benefited the resource a lot.
Thanks so much for talking us about the process and the successful parts, or the elements that made it work so well. So I see that we're at time now, but I wanted to give the opportunity for Maya and Deborah And Fahmy, if there was one question in the Q&A, I know we didn't get through many of them, but that you'd like to answer, or if there is something else that you'd like to share before we wrap up, I'll give you an opportunity. So first, perhaps to Maya.
So yeah, I actually just wanted to second what Fahmy was just saying in terms of the Interagency Standing Committee guidelines, documents. When they're shared at the country level, it facilitates the possibility for true coordination. And as a co-chair of a technical working group, I really rely on those resources to bring people together, to share their resources, to distribute their resources as one technical working group. I know often with these different agencies, we might want to create our own and whatnot, but to have this global guidance is really necessary, because also we most of the time have other jobs. You know, it's actually the coordination part is a small part of our job, so it can be overwhelming to develop this material on our own. It can take too long, it might not be good enough. So yeah, I just wanted to second that. And I don't know if I missed any other questions, but I think I'll leave it at that if that's okay. Thank you.
Great, thanks so much. And Deborah?
Thanks so much, Catherine. So I think from my end, looking at these experiences, I can say that the COVID-19 is bringing a lot of lesson learned. And also it's very useful for us to work together as partners, and also to see how mental health and psychosocial support responses is really needed within this context of the crisis, and of course in the global level. So the partnership become very important, and also I really appreciate the support of the IC reference group with all the tools, and it's really amazing. And also we also learning a lot from a lot of webinars and also like this, from learning from different countries. So it's really something that we should be grateful of. And of course it's not easy. I mean, it's not saying like the COVID-19 is giving like only good, or it's also another negative aspect, but we can see from our NS and MHPSS actors, yeah, we really learn a lot from these experiences.
Thank you so much, Deborah. And Fahmy, some final words to close our session today.
Thanks, Catherine. Developing resources and supporting global coordination would not be meaningful unless these resources are actually adapted and used. It is colleagues in the field who do remarkable work, such as Deborah and Maya, who are leaders at country level, who takes a resource and adapt it to local context and scale it up. And without their work, all what we do at the global level is not meaningful. So we are grateful for them. They're the ones who really do day-to-day sacrifice by living in difficult situation and doing serious and meaningful work. And for all our participants, I'm sure if you are attending this session, you are working in the field of public health emergencies or have interest in this field. Mental health and psychosocial support is an integral component of public health emergency. It's not the responsibility of one sector, not the responsibility of one agency. Integrated as a critical and integral component of your response to COVID-19 and other public health emergencies as a cross-cutting topic. And thank you, Catherine and EPI-WIN colleagues for this opportunity again.
Well, thank you. I'd like to thank all of you, Fahmy, Maya, and Deborah, for your time. I know it's late for some and early for others. So, and thank you to all the participants that have joined in the discussion today. I know we didn't get through all of the questions, but as I said at the start, this is part of a series. So we'd love to have your participation and questions for the next one, which will be in a month. So yeah, thank you everybody for joining together today, and we'll talk to you soon.
Thank you. Thank you so much.